Hi, everyone. Thank you so much for joining us, and welcome to today's webinar, which is entitled Linkage to Care and Treatment for Persons with Chronic Hepatitis B Infection in Dar es Salaam and Zanzibar, Tanzania, and which is being jointly hosted by Hep B United and the Coalition Against Hepatitis for People of African Origin, or CHIPO. My name is Beatrice Zovich, and I'm the Public Health Program Coordinator at the Hepatitis B Foundation and the Administrator for CHIPO. And our panelists today are going to share with us a little bit about the background and history of their project to increase treatment and care for people living with chronic hepatitis B in Tanzania. And we'll also discuss methods used and the process of data collection, their preliminary results and analysis, as well as discussion and next steps for going forward. So next slide, please. So before we begin, just a quick overview of how to participate in GoToWebinar. And so all participants in the webinar will be in listen-only mode, so you will not be able to speak. If you do encounter technical difficulties online with your computer audio, you can feel free to dial in using the phone option on your control panel with the conference line that's shown here on the screen. And at any time during the presentation, you can feel free to enter questions into the question box, and questions will be addressed by the speakers at the conclusion of the presentation. And if you have any technical challenges, please do indicate those in the question box, and we will do our best to address them for you. Next slide. Okay, so just a little background about Hep B United. So Hep B United is a national coalition which is dedicated to reducing the health disparities that are associated with hepatitis B by increasing awareness, screening, vaccination, and linkage to care for high-risk communities across the United States. And it is comprised of a total of 49 local coalitions and national organizations in 29 cities around the country, as well as 22 states and the District of Columbia. Next slide. And now for just a short background about CHIPO, which is the Coalition Against Hepatitis for People of African Origin. And this is a national community coalition that is co-founded and led by the Hepatitis B Foundation, and is comprised of organizations and individuals that are interested in addressing the high rates of hepatitis B infection among African immigrant communities in the United States. And it serves as a forum for sharing information and best practices and improving national capacity to similarly improve hepatitis B awareness, testing, vaccination, and treatment around the country. And we currently have over 35 coalition members from around the US. And HBU and CHIPO are very excited to be jointly hosting this webinar today. Next slide, please. Okay, so now to introduce our speakers. Our first speaker is Dr. Brian McMahon, who is the Director of Liver Disease and Hepatitis Programs at the Alaska Native Tribal Health Consortium. And he's also a guest researcher at the CDC and a clinical professor of medicine at the Universities of Alaska and Washington. And he will be joined today by Sean Shataker, who is an epidemiologist at the CDC Office of Global Health and their Division of Viral Hepatitis. So we're thrilled to have these two very distinguished speakers join us today. And without further ado, I will hand it off to Dr. McMahon to get us started.
Thanks very much for that introduction. And could we just go to the next slide, please? So we don't have anything to disclose, but this project is funded through the CDC Foundation that we're going to talk about, and it was funded from a grant from Gilead Sciences, and they also are providing the medication for the patients who need treatment. But our findings and conclusions are those of the authors, and they don't represent the official position of the CDC. Next slide. Okay, so the take-home message of this discussion is that hepatitis B is a vaccine-preventable disease. It's also treatable, and yet the burden of disease, as you will see, is very high in Africa. And not all patients who are living with chronic hepatitis B require treatment because we can't cure hepatitis B, and many people can suppress this virus on their own. But all require monitoring of liver enzymes, viral load, and liver cancer screening every 6 months if they're people who are at risk for liver cancer. And the updating the current guidelines may allow for testing and treatment of more individuals, and hepatitis B care and treatment programs in Africa are feasible, as we will show you. Next slide. So the background, next slide, the prevalence of hepatitis B is estimated to be 257 million people worldwide that are living with hepatitis B. And I was just on a seminar with the Liver Foundation on the weekend, and they've upped that estimate now to 292 million people worldwide. In Africa, the overall prevalence of chronic hepatitis B is around 6%. So that means there's at least 60 million people living with chronic hepatitis B in Africa. Next slide. So in 2011, the WHO organized the annual World Hepatitis Day campaigns, which recur every year. In 2015, there was a meeting. I was actually the co-chair of this committee at the WHO, and my co-chair was from Nigeria, Africa, to update the guidelines for prevention, cure, and treatment of persons with chronic hepatitis B. Using simple non-invasive tests to assess treatment eligibility, prioritizing those patients with advanced disease, and then using tenofovir and entecavir as the first-line treatment for chronic hepatitis B. And then in 2016, the WHO developed a global health sector strategy for viral hepatitis, and that strategy highlights the critical role of universal health coverage and the targets for sustainable development goals. Next slide. So in 2017, WHO released these guidelines for hepatitis B and C testing, who and how to test, and then they developed an elimination strategy that the goal was for 2030 to eliminate chronic viral hepatitis B and C in the world. And part of the strategy is to raise the awareness, promote partnerships, mobilize resources, formulate evidence-based policy, prevent transmission, and scale up the screening, care, and treatment services. Next slide. So this is the WHO's cascade of viral hepatitis prevention, diagnosis, and treatment of what they would like to achieve. And if you look from right to left, you see that you start out with prevention, and then finding those people, preventing by vaccination, finding those people at risk and testing them. If they're positive for hepatitis B infection, linking them to care, and those who need treatment, and not everybody will need treatment, get treatment, and then the chronic management of these patients, including screening for liver cancer and detecting and curing liver cancer early. Next slide. So how are we doing? Well, not too well. As you can see, there's 257,000 people over on the left-hand side of this graph. And if we look at most of those, about close to half of them are in the Western Pacific, but then there's a big chunk of people in Africa. That's the second most largest region. And you can see that of those people who have it, only very few of them have been diagnosed. So most of them, 90% of them, aren't diagnosed. And if you look at where the region is doing the best, even though nobody's doing that well, it's the Western Pacific region in Africa. There's just not many people have been diagnosed. And you can see even the next bar graph over on the right, there's hardly anybody on treatment, and then there's hardly anybody who's actually had viral suppression achieved. Next slide. So if we look at the map of the world, you can see that there's been a lot of progress, because in Southeast Asia and China, that area used to all be red, just like Africa. Most of Africa is red. So they've made some progress in those parts of the world. But you can see in Africa, most of the countries are red, meaning that they have more than 8% prevalence of hepatitis B in the population. What's not shown on the map is there's some indigenous people in various parts of the world, including the Aboriginals in Africa, the Maoris in New Zealand, and also First Nations people in Canada, and the Yupik and Inupiat people in Africa, I mean in Alaska, that aren't shown, that also have high rates of hepatitis B. Next slide. So here's where we are as far as the prevalence goes. It's highest in Western Pacific, although that's come down because of vaccination being very successful there, and in Africa. And then you can see that the next area is the Eastern Mediterranean. So Africa is right up there with 6% prevalence. As far as mentioning vaccination in Africa goes, they're doing a pretty good job in most countries with the Gavi, the Global Alliance Vaccine Initiative, by giving the hepatitis B vaccine, but it's only given with the pentavalent vaccine starting at 2 months of age. So there is no birth dose in most of the countries in Africa, so they're not preventing transmission perinatally. Next slide. And here's just the individual rates in some of the countries in Africa that you can see, with some countries having extremely high rates. Again, these are based on small sero surveys, so they don't necessarily reflect what's actually going on. But you can see there's a lot of hepatitis B in Africa. And where we've been working in Tanzania, it's been estimated to range between 5 and 17% of the population infected. Next slide. But what we see here in results from the HIV Impact Survey, which is a survey that was taken, a large survey looking for the prevalence of HIV in Tanzania. It's been shown that this is the prevalence that they found overall in the mainland of Tanzania. The prevalence of hepatitis B was 4.2%. In Zanzibar, it was 3.6%, and that survey was done on the largest island of Zanzibar, which is Ungaja. And then when they looked at HIV alone, they found that HIV positive persons who also had hepatitis B, that was 5.2% of HIV persons had hepatitis B, and 3.4% of HIV infected persons didn't have hepatitis B. Next slide. So the mortality over a person's lifetime is 15 to 40% of these patients develop cirrhosis, and that can lead to liver cancer, liver failure. And there's estimated almost 900,000 deaths per year, and that includes the liver cirrhosis and liver cancer deaths. Next slide. So this just kind of shows it dramatically that of those people who get chronic hepatitis B, anywhere from 12 to 20% will end up with cirrhosis, and following those up, many of those will end up with liver cancer or decompensated cirrhosis, liver failure, and die of liver failure, or require a liver transplant. Next slide. So the liver mortality by region in Alaska, as you can see, when you look at this slide, the highest mortality occurs in the Oceania, which is the Western Pacific area, and then Sub-Saharan Africa is number 2, and Asia used to be number 2, but now Sub-Saharan Africa is number 2. And the reason for that is that in Asia they are vaccinating newborns in many countries, and also many countries are instituting programs to detect hepatitis B, link them to care, and that's reducing mortality. Next slide. So one of the leading causes of death in Africa is liver cancer, and of the cancers worldwide, liver cancer, depending on which source you look at, is either number 2 or number 3 worldwide cause of cancer death. And you can see that in Tanzania, it's between 5 and 6.1 per 100,000 persons. Next slide. And most of those, are more than half, are due to hepatitis B. The other thing that actually we are confirming with our study is that liver cancer usually occurs in people after 40, men after 40, women after 50. But in Africa, you can see that distribution of liver cancer due to hepatitis B, which is in the dark lines, is really shifted to the left, to younger people, peaking at between 30 and 50 years of age, which is not seen in Asia. And then with hepatitis C, There's not a lot of liver cancer due to hepatitis C in Africa, but it's peaked. It's peaking earlier, or peaking later, I should say. Now, one of the reasons we think this is the case could be that there's a lot of exposure to aflatoxin, which occurs naturally in Africa from fungus contaminating grains and peanuts and other foods, and that's a very carcinogenic compound. And when somebody who has hepatitis B is exposed over and over again to aflatoxin, it looks like that really increases the risk of liver cancer. So we can't prevent the aflatoxin, but if we can vaccinate people, that will prevent them from getting liver cancer just because they can't get hepatitis B. Next slide. So these are the WHO guidelines, and just to kind of, rather than me taking you through this for time's sake, I just will say that this depends on whether or not a country can actually measure the level of virus. If they can't measure the level of virus, then what has to be shown is that they have cirrhosis of the liver, or that they've got very high liver enzymes and they're not coming down, and they're hepatitis B positive. If, on the other hand, you can measure viral load, then the WHO cutoff that was picked, because in 2015 that looked like the best cutoff, was 20,000 international mLs in somebody that had elevated liver enzymes that were persisting at least more than one time. And if they were between 2,000 and 20,000 international units, then as long as their ALT levels weren't more than a couple times upper limit of normal, the treatment was deferred. I think we're moving to treating them now all the way down to 2,000 international units, and Sean will show you some data that suggests that that might be the case. Next slide. So in Africa, we estimate that about a third of people who have hepatitis B will need to be receiving treatment. The other 2/3 will suppress the virus by themselves as they get older and not need treatment. However, right now, of those 21 million people who need treatment, only 1% are accessing treatment. So that's a pretty sobering number. Next slide. And this treatment is lifelong. If you stop it, the chances are about 70% that they'll relapse again. The two things, criteria for stopping treatment, is if they have this marker called hepatitis B E antigen, which is not measured in Africa very often, and they convert to E antibody and their liver enzymes go down to normal, you usually can get away with stopping it. Or they also have hepatitis B virus DNA that's non-detectable, or they lose the marker of hepatitis B surface antigen, which is the protein of the covering of the virus. They lose that marker, then we can stop treatment. Now, hepatitis B does not, you can't cure hepatitis B because the virus forms a mini chromosome in the liver that persists for the life of the person. So it's a DNA virus, and we all know that, for example, chickenpox can reactivate as herpes zoster later in life. Hepatitis B virus infection, even if you recover from the initial infection, you can have a flare of hepatitis B under the right circumstances. And for those who have recovered and lost surface antigen, either initially when they first get infected or over many years, any immunosuppressive therapy can react the virus. So if they get cancer therapy or immune therapy for like rheumatoid arthritis or one of those things, you can reactivate the virus. Next slide. And so one of the other things that, at least in the United States and Europe and in China and in Asia, are surveillance for liver cancer. And the guidelines that the WHO recommends, and we use, for example, in Alaska, we have a hyperendemic population of Alaska Native people living along the Bering Sea coast with hepatitis B, is every 6-month alpha-fetoprotein and liver ultrasound. And if we can find these tumors when they're small, when they're under 3 centimeters, you can actually burn them out with a needle hooked up to a radiofrequency ablation machine. It's an outpatient procedure essentially, and they're cured. or you can resect it if they get up to about 5 centimeters. Once they get too big and they're not a transplant candidate, there's nothing we can do, nothing. There's no chemotherapy, there's no radiation therapy, there's nothing else that we can do to cure liver cancer. So that's why prevention with vaccination is the most important tool that we have. In fact, if you look in the United States at all the cancers that we have, breast, colon, etc., all the death rate to all these cancers in the last 2 decades has dropped significantly. Liver cancer is the only cancer in the United States where the death rate has doubled in the last 2 decades, because we don't have good chemotherapy and good treatment if we don't find these tumors early and people are asymptomatic when they're carrying hepatitis B, and until the liver cancer gets big enough to form symptoms. The risk factors besides cirrhosis are family history, persons over 40 years of age. But now, as I showed you in that one slide, that I don't think applies to sub-Saharan Africa. I think we need to screen at an earlier age in sub-Saharan Africa. Next slide. So how do we implement the guidelines? Well, we need training programs, materials for providers. We need to be able to use non-physician or licensed providers to do a lot of the training. We need the capacity to test hepatitis B virus DNA and reliable serologic tests. We need inexpensive platforms. We need clinics of excellence to guide these countries to manage patients with hepatitis B. And we need to institute hepatocellular carcinoma surveillance, especially in areas where they can treat these tumors with local ablation. Next slide. So this is the Tanzania hepatitis B program, and I'm going to take you through the first part of this, and then Sean's going to take over. So my involvement started in 2008, if I remember correctly, working with the CDC on a project on hepatitis B and HIV. Then we moved on to get this grant to do this program that Sean and I are involved in. Next slide. And Aaron Harris was also one of the founders of this program. He's moved from the Division of Viral Hepatitis recently, but he gets a lot of the credit for, and you'll see a picture of him for this program. So the goal of this program was to establish 2 clinics of excellence that would implement the hepatitis B management and treatment guidelines that the WHO had. And so the clinics we picked were Nazimojo Hospital in Stone Town, Zanzibar. That's where I had worked on the HIV hepatitis B project. And then Muhimbili Hospital in Dar es Salaam, which is one of the few hospitals in Tanzania and even in Eastern Africa that has a functioning gastrointestinal GI department with faculty and fellows. To implement a model HBV care and treatment program, to evaluate is this program feasible and is acceptable by the people, to evaluation the impact of the disease outcomes, including can we reduce liver enzymes and virus levels, and to increase the capacity of the healthcare professionals to care for patients with chronic hepatitis B. Next slide. So the WHO guidelines, as I mentioned, were developed in 2015. The 2 recommendations, as I mentioned earlier, were to do hepatitis B virus, where hepatitis B virus testing was not available. We needed to show that they had compensated or decompensated cirrhosis, and we used the APRI, which is this little formula of one of the liver enzymes, the AST to plate ratio formula. And then where hepatitis B virus DNA was available, which was the guideline was to monitor people over 30 with ALT and hepatitis B DNA, and if that level was above 20,000 and their ALT was elevated, then they were eligible for treatment. And as I mentioned, only tenofovir and atecovir were considered treatment. Pegylated interferon is really impossible to give in Africa, except in maybe a very few places. Next slide. So we initially started with the National Blood Transfusion Service. their routine screening for HBsAg, anti-HCV, and HIV. So at the blood banks, that's essentially the blood banks, they routinely screen for these markers. And what they were telling the people at the blood bank was, if you have HIV, well, here we'll hook you up to the HIV program. It's well functioning, very well funded. But if you have hepatitis B or hepatitis C, go to your hospital and see what they can do. And they would say, well, we don't have any resources. So that's where we were getting most of our patients from the blood transfusion services. We also got patients, they started screening pregnant women in these facilities. And we also got some of the key population patients were screened, including injecting drug users, MS, men who have sex with men, and other groups. And inpatient clinics with liver disease were getting screened. And then there was some community events where people were encouraged to get screened also. Next slide. So here's a picture of Aaron and head of the GI department in Dar es Salaam at Muhimbili. And this department has a very well-staffed and highly trained group of gastroenterologists. And Aaron is the one who put a lot of these slides together. And he once in a while he'll wear a suit and tie, but usually he's pretty casual. Next slide. And here's the hospital in Zanzibar that I started working with in 2008, Nazi Mojo Hospital. It's not a medical school like Muhimbili, but it's got specialists. They got their first gastroenterologist while we were doing this project. They have a really excellent group of physicians, and as far as the makeup of people's beliefs, Zanzibar is 90 to 95% Islamic, very tolerant society, very easy to work with, and the mainland is about 40% Islam, 50% Christian, and 10% of other religious preferences. So Nazi Mojo is a public hospital. It's the referral hospital for Zanzibar. Zanzibar, by the way, used to be independent. They were taken over by Tanzania, but they enjoy a status which is similar to what Puerto Rico has with the U.S. It's independent for all of its functions except for a couple of things, has its own parliament, etc. But unfortunately, this hospital doesn't have the capacity to do HIV DNA testing, whereas Muhimbili does. So we have to send those specimens across to Muhimbili. They don't have endoscopy, although now they do because they just got a gastroenterologist. But they have the Gene Expert platform. This is a platform where you can run a variety of viral tests on this platform and bacterial tests. It's put in by the WHO into many hospitals in Africa. It will do HIV testing, hepatitis C testing, hepatitis B testing, and TB testing, and mostly it's used for TB and HIV. But at this Nazi Mojo, there's 3 of these Gene Expert units. They do have ultrasound available, and the goal was for them to recruit 600 hepatitis B chronic patients. Next slide. So the methods, and I think I'm supposed to give the first part of this, but please interrupt me, Sean, if I'm not. Next slide. So again, we were able to get the CDC Foundation with a project from industry, an industry grant. It came from Gilead. The total funding was $440,000. We wanted to enroll 2,000 patients, and we got the free medicine also from the drug company. And turned out we way underestimated the cost of the viral testing. So we did need to get CDC itself to kick in some money so we could finish the viral testing. Next slide. The project was to go from January 2017 through the end of this year. And people eligible were anybody over 18 years. And most of the patients, as I mentioned earlier, came from the blood banks, inpatient, outpatient clinics, household contacts of infected persons. And we were only dealing with people who didn't have HIV. Those people with HIV go to the HIV program and they get tenofovir-based therapy. So they're covered for Hep B and HIV. And and they had to be hepatitis C negative because we wouldn't be able to tell whether their elevated liver enzymes were due to hepatitis C or hepatitis B. And we did a goal was to establish these 2 clinics. Next slide. So we used the APRI to see if they had a stigma of cirrhosis, and then if they had any of the clinical stigma, and those of you who are clinicians or nurses will recognize these stigma that are listed below, we would put them on antiviral therapy, or if they had a viral load above 20,000, elevated ALT at least twice, and they were over the age of 30. Next slide. So this is kind of the recruitment, the way we recruited patients. Once they were recruited from the places that I mentioned, if they were positive for HIV, we sent them to the HIV center where they were going to get covered for hepatitis B with antiviral therapy that they use. If they're C positive, we counsel them, but right now there is not a program to help those people with hepatitis C. And then we referred them to our clinic, and then they went through the process of deciding whether or not they were treatment eligible or not. Next slide. And then I kind of went over this earlier, but we evaluated these patients with physical examination and a lot of lab tests listed below. And if they met the treatment criteria, they were put on treatment. If they didn't meet that criteria that I mentioned earlier, then they weren't put on treatment. Or if for some reason or other they got put on treatment, but turned out that when we reviewed it, they didn't meet the criteria, we would stop the treatment. Next slide. So the raw data is transmitted quarterly for cleaning and processing from Dar es Salaam to Sean, who has done a phenomenal job of cleaning up and putting the data together. He uses SAS version 9.4 for analysis. Next slide. Okay, so Sean's going to take over from now, and I will minimize myself and mute myself.
Thank you, Brian. Go to the next slide. All right, so this chart shows the summary of recruitment for the program in its first 4 years. Overall, you see that over 3,500 people were invited into the program. 29 in total were disqualified or not eligible based on being HCV antibody positive. Another 16 were ineligible for being HIV positive, and 1 person was infected with both hepatitis C and HIV. Another roughly 650 refused or opted out, resulting in 2,927 total enrollees. 2,326 of those were from the Morbidity site in Dar es Salaam, and then 601 at Manazi Moja in Zanzibar. Next slide. This shows the age and sex distribution of those enrolled in the program. As you can see, the majority of them are male. Overall, 66% were male, and they were relatively young cohort. The median age in both sites was just 34, and 69% of those enrolled were under the age of 40. Next slide. This is a summary of the treatment eligibility for those who were eligible for treatment. In total, 329 enrolled patients were eligible for treatment, which was 11% of those enrolled. About half of them were eligible based on a diagnosis of liver cirrhosis. 71% of them had an APRI score of greater than 1.5. Obviously, these are not mutually exclusive. And then just 5% were eligible based on their viral load and persistently elevated ALT. Next slide. This slide shows the eligibility, which is mutually exclusive. So you can see just based on APRI alone, about 47% were eligible. Another 26% were eligible just by cirrhosis. And then 22% were eligible by both APRI and cirrhosis. 3% only gained eligibility solely by their viral load. Next slide. This shows the care continuum of those enrolled in the program based on their treatment site. As you can see, the majority of them came from Dar es Salaam. 98% of those enrolled had a complete first clinic visit. 11% of those were treatment eligible, and 10% of those enrolled actually received treatment. 50% of those enrolled went on to a second follow-up visit. 18% had 3 visits, 5% had 4 visits, and only 2% so far have had 5 visits. Next slide. This is the care continuum for number of visits stratified by treatment. The green is those who have been treated, and yellow are not treated, whether they were ineligible or eligible and just have not been started on treatment yet. So as you can see, the majority of those coming for follow-up visits are not treated, but the percentage of those each visit that were treated has increased. For example, 10% of those with their first visit were treated compared to 20% of those who came back for their 5th visit. Next slide. I'll be going through some proximal disease outcomes for those treated, which are shown by the blue line, compared to those that were not treated, shown by the green line. This chart shows their median HBV DNA levels. As you can see, those who were treated, the level went down very quickly over the first 3 visits from a median score of 3,000 down to 0, while those untreated had a steady viral load level between 500 and 600 for each visit. Next slide. This shows the outcomes in median APRI score. For those treated, once again, you can see that over their first 5 visits, it went down from a median APRI score of 1.3 down to 0.4, which then matched those that were not treated, which had a median of about 0.3 for each visit. Next slide. This shows the median ALT scores, and once again, you can see those who were treated improved quickly from a median of 47 down to 22 at visit 5, which matched those untreated who had a score between 20 and 25 for all 5 of their first visits. Next slide. This is a summary of morbidity and mortality among those enrolled. We had adverse events reported for treatment for just 1 patient who reported drowsiness and discontinued treatment. 9% of enrolled people overall had a diagnosis of liver cirrhosis. Just 1%, but 40 enrollees were diagnosed with hepatocellular carcinoma, and 15 patients had a reported death. But one important thing to note here is the relatively young age of those in the program who have presented for liver cirrhosis and HCC, which is just 36 and 38 median age, respectively. Next slide. So over these first 4 years of the program, we had 2 clinics of excellence established to provide HBV care and treatment following the WHO guidelines. There was successful recruitment, actually exceeded the proposed enrolled number, and care is ongoing. And challenges include missing viral load and liver enzyme data, high cost of HBV DNA, which Brian mentioned earlier, and monitoring adherence to the treatment and follow-up appointments. There's a high demand for HBV care and treatment, which is why we exceeded those enrollment numbers. And another challenge was many patients presenting with advanced liver disease. Next slide. And then I'll just go over some of the partnerships that made this program successful. First of all, technical assistance was provided to our Tanzanian partners, including training and education over the natural history of hepatitis B, serologic and molecular markers for viral hepatitis, WHO guidelines, management of patients on treatment, and patients with advanced liver disease. Assistance was also provided to guide them with the study protocol and procedures, logistics, including drug import and shipment for viral load from Zanzibar to Dar es Salaam. And of course, we provided data management and analysis and help with scientific presentations and publications. Next slide. There's also support from the Ministry of Health, who helped to develop a strategic plan for viral hepatitis, including surveillance, birth dose, vaccinations, testing for pregnant women, testing and vaccinations for healthcare workers and other key populations, and following WHO care and treatment guidelines. There was a viral hepatitis lead appointed, Dr. Asma Simba, and a viral hepatitis work group was established. Next slide. And of course, there was guidance from the WHO, who was contemplating expansion of viral hepatitis activities and their goal of developing clinics of excellence and promoting viral hepatitis testing and care guidelines in country. Next slide. And finally, support from the CDC Tanzania office, who is a scientific partner who assisted with approvals and logistics when it comes to transport of specimens and drugs and organizing meetings during annual site visits, coordination of communication with stakeholders, and they acted as a liaison between DVH and Tanzania officials. Next slide. Okay, then I welcome back Brian to go over sustainability and next steps for the program.
So thank you. Let me just see if I can hook myself back. Can you all see me? I guess they're hooking me up. Okay. Here I go. Okay. Okay, I think you can see me. What I think our goal is to expand the care and treatment to the entire country and adding locations in remote jurisdictions. So the cost of treatment and care has come down dramatically during the time of this project. For example, as I mentioned, the WHO put gene expert platforms into most hospitals that are mid-sized hospitals for HIV and TB, and and all they need to do is have the cartridges for hepatitis B, which costs about $14, between $14 and $15 for the cartridge for one-time test, which is thrown away. The results are back in about less than an hour, and so this is a really opportunity to decrease the cost. We were paying $90 for HPV DNA for each test done at Muhimbili Hospital using an automated machine, which is similar to an Amplicor that's used in a lot of places in the United States. So that cut the cost. And then the cost of the medication is really down to about $6 a month for tenofovir. And so that means that if the government negotiates with the company, one of the generic companies that makes tenofovir, then they can get it for that price. And so that means that treatment can be a lot less expensive than it had been when we first started. The second, I think, thing is really important is getting the birth dose, because the birth dose is not being given in most countries in Africa. And the birth dose only costs 50 cents a dose. And there is a lot of jockeying back and forth between the Gavi folks and the WHO and other groups about funding the birth dose. And the thought is that the countries should fund their own birth dose. But that's not happening. So it would be really nice if we could get that birth dose funded. And one of our next projects that we would like to do, and we found a foundation that's interested, they haven't committed yet to funding it, would be to do a universal screening of pregnant women in both of the locations, starting out probably in Zanzibar first, and then giving the birth dose and following and seeing how successful that is by bringing back any infants whose mothers were positive for her hepatitis B and seeing if it worked. And then the second thing that's really quite quite interesting is that the healthcare workers are not screened and vaccinated. And so what's the best way to do that? Should you screen the healthcare worker for all the markers for hepatitis B, and those who've been exposed and are immune not receive the vaccine? Or is it cheaper just to screen them for the virus? And if 5 to 8% are infected, you don't vaccinate them, but you link them to care, and then you vaccinate everybody else, because it doesn't hurt to get the vaccine if you are already infected. And the cost of the vaccine is about $1 a dose. So it might be cheaper not to do the screening, except to find those people who are infected. And again, we have one foundation that's indicated some interest. They're not committed yet to actually helping us with this project, which would be the next project that we would do. Next slide, please. So the next step is to focus on the follow-up, continue the training and education, monitor the adherence of the persons that are in the project now and any side effects, which only one person has had to quit the drug so far because they had fatigue, monitor and evaluate the implementation of the protocol, evaluate the feasibility, sustainability of the program. In other words, will this program be taken over when the funding runs out by the two hospitals? And then analyze the data to evaluate the impact on the improvement of liver function and viral load. And it'll take a while to show a reduction of morbidity and mortality, but I think the slides that Sean showed about the dramatic drop in the viral load and the liver enzymes in those on treatment is proof that this really will work. Next slide. So the take-home message is that hepatitis B is a vaccine-preventable disease and is treatable in those who develop chronic Hep B, but the burden is extremely high in Africa, and Africa is much further behind in developing hepatitis B vaccination and treatment and linkage to care programs than other parts of the world. And then not all patients living with chronic hepatitis B require treatment, but all require monitoring of their liver enzymes, the viral load, and liver cancer surveillance. And one thing that's not occurring right now is we don't have really good liver cancer surveillance going on as part of this project or treatment set up so that the patients can be treated in those hospitals. They're sent to India often for treatment if they have the resources to go. So hepatitis B care and treatment programs are feasible in Africa, as our project is showing now. Next slide. So we want to thank you. These are the people that have been very helpful in this. Paige Armstrong is with the Division of Viral Hepatitis. Jeff Beckett, who's been involved from early on, and he and I started out with back in the old days of the HIV hepatitis B program about 12 years ago. Noelle Nelson, she is the director of the prevention branch at the Division of Viral Hepatitis. She's been extremely supportive and helpful. Nancy Glass, also from the CDC in Atlanta, and then in the CDC Foundation, Catherine Zibler and Brian Graff are the two administrators there, and they've been super supportive, and we thank them so much for funding this. And then the program staff and the participants in Tanzania have been wonderful to work with. It's a pleasure to go over there, and very gratifying work I think that we've been doing. And I think that might be the last slide, if I'm not mistaken. Go ahead.
Yes, I would just add a thank you as well to Aaron Harris for all of his work.
Yes, and Aaron his name should have been up there. I'm sorry it wasn't up there, because he and I are the ones who started this program, and he's done the bulk of the monitoring of it, and Sean's taken over and done a really good job. So thank you, Aaron, if you're on, and we miss you very much. So I think there's probably some questions. Should we start answering those in the chat room? Is that what we should do?
Yeah, absolutely. So thank you so much for your wonderful presentation. We really appreciate it, and it's very encouraging, the results that you've gotten. I do see one question in the question box now, and if anyone else has any, please feel free to enter them. But the first question we have is, can you speak to the limited accessibility of HBV DNA testing in sub-Saharan Africa? And do you have thoughts on why this is and how we might be able to improve diagnostics?
Well, I think that right now it could happen because in any mid-sized African hospital or large-size referral medical center is gene expert. And again, the cost of the kits are $14, between $14 and $15. So that this makes it feasible. Again, that's still a lot of money for people to pay. So it is definitely feasible now. However, a lot of people don't live near one of these regional or large hospitals, so that will be a challenge. But that's definitely feasible to get it in those places.
That's great. So glad to hear that the costs are coming down for sure. Let me pull up some other questions.
Teachers, if you want to check the chat box.
Oh, the chat box, gotcha. Okay. Oh, just give me 1 second, I'm sorry. So how much would eligibility have changed if the cutoff was reduced to 2,000 international ML?
Sean, can you estimate that from the data that we have so far? Is that possible?
I could find that out, but I'm not sure I could do it right off the bat here.
I might say, while John's looking, that we have had our colleagues in Muhimbili and Nazimojo have had several times called us and said this patient really has a lot of disease. They don't have the stigma of cirrhosis, but their liver enzymes are quite elevated. Their level is between 2,000 and 20,000, and they're not eligible by the standards that were set. Can we treat them? And we've said, yes, you can. So we will be able to evaluate the actual number that we treated that didn't meet the criteria and the reasons for that. But I think there's a considerable number of people that we use the WHO guidance don't cover. Go ahead, Sean, and if you've got any information on that.
Unfortunately, I don't have anything more specific, but I don't feel that it would change it a whole lot. Just given the mutually exclusive ascertainment of treatment eligibility, so few of them were based on DNA, and it was captured through other means like APRI or cirrhosis. So it's hard to say just how much of an effect that would have.
Sure. Well, thank you both for that. I have another question. So I assume that the Zanzibar clinic does not have lab capacity for viral load testing, but do they have any type of lab infrastructure? And has point of care testing or GBS testing been considered?
So, when the last time that Sean and I were there, and Aaron, we walked through the lab, and there's 3 gene expert machines sitting there. One's for TB, one's for HIV, but you can use any machine for any of the tests, and one is a spare in case one of the other ones doesn't work. So they can do it. They actually can do it, and that was one of the things I was hoping that we'd be able to implement. And then as far as point of care testing, one of the there is the rapid surface antigen tests. There's 2 or 3 that are approved by WHO. They're about $1 a test. It's a finger stick test, and we didn't use those, but that could be used. Again, there's not a finger stick point of care test for hepatitis B surface antibody, but if you wanted to just screen out and find the people who were infected, you could use that test, such as in healthcare workers. And if you wanted to vaccinate more widely, you could certainly screen household members of infected persons. And if they were negative for that finger stick test, you could give them the vaccine, because even if they were immune, it wouldn't hurt them. So there's a lot of things that could be done, I think, just with point of care tests.
That's great to have that accessibility, particularly at low expense. Another question was, what was the frequency of HCC in the outreached group, and what was the DNA quantity in the HCC patients who were not treated?
Sean, I don't know if you'll be able to pull that up, but we had I think there was on one of his slides, he showed the number of HCC patients that were found in both of those facilities. They both chose to try to do ultrasound on their patients that were enrolled. I don't know how frequently they're doing it, but they at least did it at the time of enrollment.
Oh, that's great.
I think if Sean can't figure it out, that's something we'll probably figure out when we actually write this up.
Yeah, I have in the slide that it was just 1% that was diagnosed with HCC, but it's something I could definitely get back to about the viral load among those.
That's a very good question, though.
Okay, perfect.
I can say something though. In Alaska, we see HCC in people that have very low levels of DNA, and even without cirrhosis, so especially in younger people. So because the virus integrates into the genome of the host cell, it can cause cancer without cirrhosis, and so that's another reason for surveillance. We can't always pick out the person who's going to get cancer.
Sure, that makes sense. So what were the relative proportions of HCC and cirrhosis diagnosis in the treated versus untreated groups of HBV patients? I think that's kind of what did you want to add to that? Or I think that's mostly what you answered.
I don't know, Sean. I think that's something we're going to have to look at. One of the big problems, I think, is the difficulty in getting people back for a variety of reasons. And one of them, of course, is COVID. But even before COVID, we had trouble getting people back. And a lot of people wanted to enroll. And then when it may be that they saw they weren't going to get treated, they decided not to come back. And the other thing that happened is that the program was advertised over the BBC, African BBC, and so people started flocking down from other parts of Tanzania and enrolled, but then it was very difficult for them to get back for follow-up. So we tried to encourage our colleagues not to enroll people outside of the immediate area of their hospital to try to improve follow-up. But follow-up has been the one thing that we've had difficulty with.
Sure, that makes sense. Were there any patient navigators that were used at all, or people who could help with follow-up and make sure people were adhering to treatment and appointments?
No, that was another problem. Was we had a really limited budget. We budgeted thinking the cost of the viral testing was going to be like $15 a test, and that was because the main laboratory for the country was going to do the testing, and they weren't going to use an automated platform. They're just going to do it with their platform, with their testing that they had, and unfortunately that never occurred. And then they set up Amplicore at the main hospital, and so there we were stuck with using that. That was before GeneXpert came out, so that really limited the ability to do a lot of extra things. And fortunately, we were bailed out by the CDC, who came up with some money for testing and have been really supportive of this project. But again, we really underestimated it, what it would cost. And that was one of the things that I wish we could have corrected.
Sure. Yeah, that's hard to know beforehand, definitely. So I think we just have a couple of questions left. Can you discuss HBV stigma in your patients and general population?
I don't think the stigma is as much as it is in China. I don't think people are. I think I'll tell you what happened though. One of the things that really got us going on this is that when I was doing with Jeff Beckett, doing the HIV hepatitis B project, we went to the blood bank and visited them, and they told us that a lot of donors who were volunteer donors, about half their donors were volunteer, half of them were donors of family members who they needed blood. But the volunteer ones were young people, and they found out they had hepatitis B, and then when they were told there was no treatment, they started sort of spreading rumors around saying, don't go to the blood bank because they'll find diseases that they won't even help you with. And so the blood bank was quite alarmed about this, and they were really wanting us to get this program going. And so the stigma was kind of the opposite, in that you're not offering us any treatment for or care for hepatitis B. What's going on here? You know, what's wrong with you? Whereas I think in some other parts of the world, they don't want to know. They don't want to get screened because they don't want to know. But we didn't find that people were hesitant about screening. They were more hesitant about, well, if you find it, can you help me? And if we couldn't help them, or the blood bank couldn't, they didn't want to have much to do with us.
Sure. Yeah, that makes sense. And different attitudes globally, for sure. So I do say that it is 4 o'clock. I know that there are a few more questions, but just in the interest of time, I think we will wrap things up. So thank you.
If I could just squeeze in one
Yeah,
thing really quick, because I did run some analysis based on those questions. So based on the 40 people that were diagnosed with HCC, 35 of them had valid DNA levels. About 50 of them were less than 2,000, and about 30% were over 20,000. And then for those 40 that were diagnosed with HCC, 25%, 10 of them had been treated.
Okay, perfect. Thank you so much for that. And thank you so much to you both for your time today and for sharing this great project, and your findings very encouraging. And we look forward to the final results. So thank you so much. And before we wrap up, we just wanted to take a few moments to quickly introduce a campaign that we are going to be starting up in a couple of weeks. And this is called the More Than B campaign. And we're going to be using it to collect stories and photographs from people who are connected to hepatitis B in some way, to be featured on social media throughout the month of May in celebration of Hepatitis Awareness Month. And this campaign will highlight the stories of people who are living with and connected to hepatitis B in some way, and will focus on the aspects of people's lives that make them, that are beyond just hepatitis B, so that make them more than B. These can include things like hobbies, family, and achievements, etc. And then we'll be featuring these stories throughout the month of May, stories from the United States, and then we'll continue to collect them on a rolling basis and feature more international stories around World Hepatitis Day at the end of July. So we would love to have you participate. Anyone who's interested, and to submit 1 to 2 photographs and a short paragraph about what makes you more than B. So we'll put the link in the chat, and you can feel free to complete the survey and share it with others. And we also encourage you to complete the evaluation form of our webinar today. Thank you so much again to our speakers for your time and insights. And please do feel free to reach out to us and to get in touch with us for any reason or any questions, using the contact information on the final slide, and to check out our websites for more information. And that concludes our webinar today. Thank you so much, everyone, for joining, and have a wonderful afternoon.
Thank you.
Thank you. All right, take care.
Bye-bye.
Bye.